Hello, my name is Dr. Julie Johnson. I am a chiropractor and a faculty clinician at Palmer College in Davenport, Iowa. I do functional nutrition with patients 1 day a week in our academic health center, and I've also been recently appointed to the VA clinic in Iowa City as part of our verdict study. I have additional certification in functional medicine and homeopathic medicine, and I'm very excited to be here today doing this presentation with Dr. Mary Balliet.
Hi, I'm Dr. Mary Balliet. I'm a chiropractor and I have a Master's of Science in Applied Clinical Nutrition from New York Chiropractic College, where I'm a professor and I teach biochemistry and physiology. I've taught in the acupuncture program and I used to be the acting dean of the School of Applied Clinical Nutrition.
What we're going to do together today is to go through a case approach to support digestive health. And we have several presentation objectives that we'd like to accomplish during our short time together.
So the first thing that we're going to do is identify the importance of addressing gut health, because we know that the gut is really the beginning of digesting and absorbing nutrition. So we got to start there. We're going to also look at two cases. In New York, I'm not allowed to do a lot of laboratory testing. So I'm going to talk about more functional testing, and Dr. Johnson's going to talk about more lab testing. And then we're going to really talk about differentiating appropriate nutrients to restore balance to the system.
Part of the thing that we realized in doing this is that a lot of our colleagues have barriers to diving into this type of work because it feels overwhelming. So in order to help you get started in this really important area, we're going to work you through a clinical thought process and have created an additional handout that you can examine more thoroughly after the presentation to help you organize that clinical information. We're also going to encourage you to formulate action steps that you can begin to take right now to help you do the work that we've been doing. The gut is truly the king. You know, it was Hippocrates that said that all disease starts in the gut. For this symposium, the focus is on gut health and athletic performance. So that's really where we're going to stay focused, because the truth is that we could spend weeks together diving into gut health alone. You're going to see our review of a very recent publication in the January 2020 journal Frontiers in Nutrition that will help develop how exceptionally important the gut environment is to athletes with respect to optimal performance, as well as, reduction of risk of injury. So let's dive into our cases.
So we're going to start here at GERD, and because digestion of protein starts in the stomach. So because we're talking about athletes and muscle mass, we are really key that we have to be able to digest our protein. So what is the most common problem in the stomach is GERD. So what I wanted to start with was a review of the literature and looking at the prevalence of GERD. Before 2014, it was believed that up to 40% of the United States general population had symptoms of gastroesophageal reflux disease. But starting in 2014, and the references at the bottom, it showed that more than 50%, that is more than one in every other person in the US general population, reports heartburn, higher than it had been even before that. What's interesting about that is that for patients who go to the gastroenterologist, so those are GI specific patients, they are suffering at GERD at the exact same rate as the general population. Our concern is that the general population is not being managed by a gastroenterologist. They're managing themselves with over-the-counter medicine that they may or may not understand all the impact. And so this is really a significant population and likely one that you will see in your practice, whether it's a chiropractic practice or you're doing nutrition. We think you're going to run into these people. So I thought it would be great just for us for a moment to review what is gastroesophageal reflux disease. So when we look at gastroesophageal reflux disease, we have to realize two things are involved: the lower esophageal sphincter and the stomach. So let's talk about the lower esophageal sphincter. You can see the arrow pointing to that. We want acid to stay in the stomach and not enter the esophagus. How does that LES work? It works by a pressure system. As food comes down, the pressure of the food opens it and the food goes into the stomach. As the food is in the stomach, the pressure then should snap that closed. So it's only when it stays open that acid should go up. And again, we really want it to stay shut. Why? Because it's critically important that that acid stays in the stomach. It has seriously important functions, the first of which is to digest proteins. Protein digestion is reliant on an enzyme known as pepsin, which is made when you convert pepsinogen into pepsin only in the presence of hydrochloric acid. Additionally, we cannot absorb any ion that has a positive 2 charge. Those are called divalent cations, and they are calcium, magnesium, iron, and zinc, to name a few. Now, calcium, we're going to focus on quite a bit in this because on the case that we're going to do, we're going to talk about a patient who did not have enough absorption of her calcium. And then finally, we want to remind ourselves that it's so important to have acid in the stomach to kill foreign microbial organisms, particularly things like candida and other pathogenic bacteria or viruses that we definitely don't want getting into the small bowel, and we don't want them then to end up in the large bowel, which is going to be what Julie's going to talk about later. So we want to start to prevent abnormal microorganisms by having stomach acid. So first line of defense. Now, looking at the literature, there are going to turn out to be 3 risk factors. And the patient I'm going to talk about had 2 out of 3 risk factors. And she did have a hiatal hernia. 10 years before I saw her, she had been diagnosed by her gastroenterologist with a true hiatal hernia. And you can see by the lovely pictures that Dr. Julie found for me that hiatal hernia is a functional problem because the diaphragmatic hiatus for the esophagus, it can get stretched. A piece of the stomach can end up above, and that then by pressure alone will open the lower esophageal sphincter, which is a pressure valve, as we talked about before. And so now all of a sudden it's going to stay open and acid can reflux back up into the esophagus where we do not want it, because it will burn it. That won't be good. The second problem that is a global epidemic is obesity. Now, my patient that I'm going to talk about did not have this one, but obesity is a huge risk factor. We know from the data from the CDC and others that now it's as many as 1 in 3 Americans are considered obese, and the problem is twofold. One, it's a mechanical issue where just that extra weight of the abdomen is pushing the contents in, which then pushes the stomach up and can result in a thing that we would maybe call a functional hiatal hernia, where we're now just getting too much pressure outside the stomach, pushing things back by pressure alone into the esophagus. That's not a good thing. But secondly, as you can see from the slide, visceral fat is actually not a garage. It's like a very busy warehouse. And when it is working really hard, what ends up happening is you make what's known as inflammatory cytokines, things that perhaps you've heard of like interleukin-6 or tumor necrosis factor alpha. And these inflammatory cytokines can then lead to pathological conditions such as cancer. And the problem with that is acid in the esophagus can lead to esophageal cancer. So we definitely would like to avoid that. And finally, stress increases the risk. The reason that stress increases the risk is under stress, acute stress we make epinephrine, and in chronic stress we make cortisol. Unfortunately, epinephrine in particular causes a lower esophageal sphincter to spasm because you're not now in rest and digest. Bizarrely though, sympathetic innervation from epinephrine decreases stomach acid. Now that's a really interesting problem. If I have less acid and a reflux, I should be okay, right? But the problem is that without enough stomach acid, the pyloric sphincter or exit from the stomach into the duodenum, that does not open. Therefore, everything stays longer in the stomach. You feel more pressure in there. And now if it spasms, what acid you do have can come up. And chronic stress just shuts off digestion. So now, again, I'm not making enough stomach acid, but I am also at risk now, because now instead of food going down, food is coming up. In acupuncture, they call that a stomach-spleen imbalance, because normally they say food should go down and the immune system should build up. And in a stomach-spleen imbalance, the immune system goes down and the acid comes up, which we can now explain both by this system and things Julie's going to talk about later, how important the immune system is to the gut. So, what about those people who really do have excess stomach acid? There are some of them. So there are 3 things that turn on the proton pump that makes stomach acid for you. One is just being in rest and digest, or acetylcholine, mediated by the vagus nerve. But another way is the H2 histamine receptor. And this is how many drugs work. They block this. But my hypothesis for my case, and a hypothesis in the literature, is that food and spices can produce histamine that can lead to an increase in acid. Now, histamine is a very interesting thing. When histamine binds to the histamine receptor in your sinuses, or makes them all congested, and your nose runs and your eyes water. So if you had an actual allergy, what you would notice is you would be congested, your nose might run, and you would have excess stomach acid. Many of us have experienced this with wasabi. And so this is a really interesting idea. And so my patient did in fact have a histamine problem, as we're going to see in a second. What is your patient going to come in with? The majority of patients who are going to the store are seeing shelves like the one that you see in front of you, or they're getting these medications from their doctor. Western clinical medicine treats gastroesophageal reflux disease by using antacids. There are 3 main antacids: proton pump inhibitors, H2 histamine blockers, and our friend Tums. The problem with all of these, they create a drug-induced nutrient depletion that really has to be addressed right away. So if we look now on the next slide, we will see that the medications, whether they are proton pump inhibitors, H2 histamine blockers, or Tums, deplete protein, calcium, iron, zinc, and folic acid and B12. Let's talk about each of these for just a moment. When I don't have enough protein, I'm going to lose muscle mass. That is a huge problem for athletes, but everyone is an athlete. So that's a huge problem as we age, because as we age, we are going to necessarily lose some muscle mass as well. It's harder to keep it. So we want to have enough stomach acid to digest our protein. What if we don't have enough calcium? Well, then we're going to get osteoporosis, tooth decay. And because the heart is highly dependent on calcium to have contraction, we're going to have cardiovascular disease risk. Without iron, we're going to get anemia and a lack of energy. Without zinc, wound healing, trouble breathing, and poor digestion, because zinc is necessary to make hydrochloric acid. And folic acid and B12 should always be given together, because they work together, not only to do DNA repair and mitosis, but also to get rid of elevated homocysteine levels, the #1 cause of cardiovascular coronary artery disease. So these are really important things that have to be dealt with if patients are taking these antacids of any type. So what we'll see in a moment is that this is not all that's wrong. So in the next slide, what we'll be able to see is that there is now ample evidence, and you can see it with the circle there. Proton pump inhibitors cause osteoporosis. So all of this idea that we're just going to up women's calcium levels to just these massive amounts, not really evidence-based at all that women should take high-dose calcium to prevent osteoporosis. What we have to do is make sure they're absorbing the calcium that they are having. And that way, we don't get a medication-induced osteoporosis. And I recommend that you look at all of the other drugs on this slide that are commonly prescribed that also can lead to this. But for this one, we're going to focus on this because my patient was diagnosed with osteoporosis. So what about the fact that she was on both? We're going to see a proton pump inhibitor and an H2 histamine blocker. H2 histamine blockers recently, in a recent article, as you can see there, that's listed below, they showed that they inhibit the cytochrome P450 system. Now, the cytochrome P450 system in your liver is the major detoxifier of what's known as xenobiotics. That's all the things we take in our body that are not nutritional. So that means drugs, whether they're prescription or over the counter, alcohol, things that we just are not really nutrition. If I inhibit it, that means that any other drug I'm on, I'm going to increase the pharmacological action of that drug. And now instead of being in the diagnostic, or rather I want to say the therapeutic range, now I'm in the toxic range. So the very system that should detoxify is going to actually cause more toxic problems. And the most famous H2 histamine blocker is Zantac. So what did I want to do? I wanted to have an alternative treatment for my patient, change her diet and add some supplementation. I wanted to follow Royal Lee's advice that there is a battle going on between those who are trying to promote better nutrition and the food manufacturers who insist on making products worse so they can be sold for less. So this is not a picture of my patient, but my patient is a 67-year-old woman who was very physically active before she really started having a lot of issues. Her acupuncturist was a student in my pharmacology class where I talked about drug-induced nutrient depletion. He was aware that she had a polypharmacy issues, and therefore he believed that that may be the cause of why acupuncture was not getting her better when he thought it should have. And she was unable to have her activities of normal and daily living. So let's talk about her. She's on the next slide. So she's 67 years old when I started working on her, and she came in with the chief complaint of fatigue and muscle weakness. She could not walk even out to the mailbox. She really was so weak. And she came in, interestingly, with her husband. They were desperate for some answers, and they were both very well educated. Her Western clinical diagnoses, because she was so organized, she came in with the printout from her medical doctor, and she's just been so helpful to my class. I've used her for cases for my drug interaction class. She's just been amazing. But she was diagnosed with allergies. So I was like, well, there you go. That's definitely going to be a problem. And she had asthma as well. She has RA, and not listed on the slide, she actually also has Sjogren's syndrome. She has been diagnosed with GERD, non-intractable migraines, osteoporosis, and intriguingly, drug allergies to NSAIDs, statins, and prednisone. But she was on an H2 histamine blocker, and we now believe that that was the cause of her reaction to those drugs. So what was she on? Absolute polypharmacy. Before I even go into that, what I want to say is there's never been a randomized double-blind control trial with any patient given more than 2 drugs. So we don't really know the impact of the interaction of these drugs. She was given Allegra, which, like Claritin, is a histamine blocker, but an H1 histamine blocker. She was on Pro Air, which is a steroid rescue inhaler for asthma, critically essential for asthmatics. She correctly was given hydroxychloroquine sulfate for RA. It is really kept her RA under control, and I highly recommend her staying on that. Of course, chiropractic, it's outside her scope. I worked very closely with her medical doctor as we were working with this. So I gave reports to him, and we stayed very much together working on this case. She intriguingly was on 2 antacids, a proton pump inhibitor in the morning, and an H2 histamine blocker at night. The reason I found that odd is proton pump inhibitors keep your stomach acid down for 24 straight hours. H2 histamine blockers only for 12. So I kind of got the 12 overnight thing, but why a double hit, I wasn't sure. I did question, was that necessary to the doctor, deferring to his thing. You'll see he changed it right away. And then because she had osteoporosis, she was on Avista. Additionally, then I did some functional tests that I'm going to talk about on the next 2 slides. I'm going to use Chapman's reflex from an osteopath and standard processes system survey. So moving to Chapman's reflex on the next slide. So Dr. Chapman was an osteopath, and he found that certain spots that you can't really see well on the slide, but you can search this. There's a great little PowerPoint on the internet about all the Chapman's reflexes. At the midclavicular line on the left-hand side at the bottom rib, she could barely stand to be touched. And that is diagnostic, says Dr. Chapman, for a problem with the stomach. Now, she had a Western clinical diagnosis anyway, but I was going to use that as evidence that we did a little bit better, so that we didn't need more GI imaging, that I could use a sort of functional test. So, but initially, so very painful. On the next slide, on the system survey for standard process, she did the entire thing, but I want to focus on group 6, which is stomach. You can get 0, you never have it. 1, you have it occasionally. 2, you have it maybe every couple of weeks. Or 3, you have it all the time. You notice that every single one, there are 9 questions, which you can read at your leisure. She scored a 3. So she had a score of 27, the highest possible score you could have on stomach dysfunction. She had a 27. So she was really struggling. So what do we do to address all of these things, as we can see on the next slide? So the first thing is we did a food allergy elimination diet. I was sure she had a food allergy because she had both migraines and allergies. So we know that although she had some seasonal allergies and some other things, the likelihood with migraines that it is a food allergy is really high. Much to her dismay, it turned out to be cow dairy. She was very upset about this. And she was getting the majority of her protein from cow dairy. So I had to do a lot of other work with her to get her to eat some other protein, because if you go back to the slide, which we're not doing, but if you do look at it, she doesn't really like meat. So what I had to do is like, well, let's try some beans, let's have some fish, let's have some salmon, let's eat some eggs, how about some chicken? And if you don't want to have beef, that's okay with me. So that is what she did. And although she struggles with it, I said, look, I know you don't feel good when you have it, but what we're going to do is we're going to do some supplementation so that you digest it. And that way you won't have these negative reactions, and you'll notice that you won't dislike it as much. That was my goal with her. So we'll see on the next slide what we did for that. So the first thing I did was I knew that she also had rheumatoid arthritis, and she had all this inflammation. And we might remember that even though she wasn't obese, that inflammatory cytokines and inflammation can increase the problem with having increased stomach acid and the hiatal hernia. So what did I do instead? I said, let's have some supplement intervention here. So the first thing I wanted to deal with was her inflammation, because even though she didn't have obesity, we saw that inflammation could lead to GERD, and she had a diagnosed RA. So I went onto the literature, and I saw that both fish oils and evening primrose oil decrease inflammation due to RA. So we gave her both fish oils and evening primrose oil, and she's still taking it, and it's on her paperwork at the medical doctor, so it is documented there as well. The second thing is I could not, it's outside my scope, and I did not want to take her off of her antacid medication until she was asymptomatic. So I needed to find a digestive enzyme that worked at a higher pH. Additionally, it needed to contain L-glutamine. L-glutamine is the preferred fuel of the intestinal cells, and it's critically important for their health and repair, which we needed to do. And so I found a product that had both L-glutamine and digestive enzymes that worked at a higher pH so that she could still stay on the medication and still digest her food, especially her protein. Her GP eliminated the H2 histamine blocker at night because that study had come out about that it could cause other problems, and she was on polypharmacy, so he got on board with that right away, and only then gave her one omeprazole at night because nighttime is the worst time of the day for GERD. And so initially that was what we did. On the next slide, you'll get to see how it went. So the first thing at 6 months, this took time, she was 67 years old, so I kept on track with her every month, but we did a big follow-up at 6 months because I wanted to give her time to really have this work for her. So her Chapman's reflex, very reduced pain. So I was like, wow, functionally, it looks like your stomach is doing better. So then we redid the system survey. Now I did that at 1 month out, 3 months out, but at 6 months out, we really had the biggest change. So that's the one I'm giving you. So here we are, a drop of 15 points in 6 months with a patient who'd been diagnosed 10 years prior with a hiatal hernia and the beginning of her GERD. And you can see that all of those things went down except for the lower bowel gas several hours after eating. And I have now a new plan because of Dr. Johnson. As she gives her presentation, I was like, oh, I think I know one more thing I can do. So again, no matter how long you've been doing this, and I've been doing this for 31 years, 32 years actually at this point, you can always learn something new. So I hope you're learning something from us. So she was thrilled. In fact, I ran into someone who knew her who said to me, thank you, because we're back to walking with each other. So that was very sweet.
To me, one of the things that was so impactful in working on this presentation with you was that reminder about the pylori. You know, we learn all of these things when we're in school, but how explaining to the patient that they need acid in order for that to open, and all the things that can happen after that are just so huge.
Thanks, Doc.
Okay, so and Dr. Mary, just one more thing. Weren't you saying that, you know, GERD medications are the #1 prescribed
drug in the world? In the
world. I think that's a really important point to make. And I'm going to build off of that to say that if you have an environment that doesn't have enough acid, that's where the microbiome can become imbalanced and things like Candida can begin to grow and thrive. So we're going to make a transition at this point to talking about dysbiosis. And really, to start, we've got to take a look at this term. Anything really, like disease or dysfunction, would demonstrate something that is out of balance. So that's what dysbiosis is intending to say here, an environment in the gut that's out of balance. And it's also, I think, important to realize and remember that this term in and of itself is still under investigation because we're trying to understand what the microbiome connection is to disease states in the human body. But proceeding forward, we're going to stick with the foundation that there is some connection and initial evidence of a link to nutrition-related diseases like diabetes and obesity, and then systemic functions of immunity and brain function, thinking about that connection between gut and brain. Something that's really important to remember here is that the gut environment changes and it responds to external stimuli. It's malleable, and that's huge because the potential truly exists here to make an impact. And that's where the idea of precision nutrition through testing really comes into play. So we've forwarded to the slide here, so we want to stay right here. If we could go back, we're going to stay with that slide that is a review of the role of the gut microbiome in personalized sports nutrition. This is what I found. You know, a lot of preparation was made for this presentation, and certainly with the brief period of time that we have, it just isn't enough opportunity to do justice to this topic. We'll really urge you to consider reviewing this material on your own. It's huge in showing that there really is this connection between, you know, what we put into our body and what we get out of our body with respect to performance. And that's not only for athletes, but for any of us. I fully admit that I am no athlete. I never have been, you know, but I know how to ask good questions. And I, like so many others, just want to have a level of fitness and vitality in my life, a good quality of life. And I certainly want to see that for my patients. What I haven't really observed in those that I see working with athletes is, you know, an investigation into the gut health for the athlete. Are they having a bowel movement every day? Do they have indigestion? Is there any heartburn? That's an issue there. So I'm hoping in my section of this presentation to really expand the conversation with regard to stool and saliva testing that may be completely, new to you if you've not been exposed to that before, in order to maximize gut health. And as a result, again, of preparing for this presentation, wondered what would be the impact if an entire team was having their gut health assessed, not only through this type of testing, but through the functional means that Dr. Mary was talking about. How would that teamwork be impacted? How would their connection together be impacted with respect to gut-brain on that? So moving to the next slide, I couldn't help myself but to say no guts, no glory, right? This is a perfect opportunity to do that, because the truth is that there's so many mechanisms that are at play here that impact multiple performance measures. The question that was asked in that review of the role of the gut microbiome in personalized sports nutrition was really whether it could be leveraged. Could the microbiome be used to predict performance in response to diet or training interventions? It goes back to that potential of influence here. Nutrition is still the primary factor of influence, no doubt, but there really is more to the story to consider. Part of what I discovered in this process was that Harvard researchers are attempting to determine, for example, if certain microbes exist in elite athletes that could be shared with others to improve performance. It is also already known that there is a spike in bacteria that breaks down lactic acid post-marathon in certain runners. So again, the question is, could that be used to decrease lactic acid and speed up recovery in other athletes? And if so, how? How can that be done? This is really a field that's wide open for discovery in the coming decades ahead of us. So moving forward to the next slide, the question really is, what about gut bacteria in athletes? I found an article published by Viome in July of 2018 that identified 9 ways that I'm going to share with you that the gut microbiome impacts athletic performance that we know, right? There could be many other things that are happening we're not aware of. This is what we know. So the gut microbiome really plays a significant role in inflammation to either increase it or decrease it. Why is that important? Well, inflammation slows recovery. And when you have someone that is an athlete and they have specific roles that they're playing, within a team, or specific goals and performance measures they may want to reach individually, when inflammation slows recovery, that's truly a problem. The other aspect is a boost of energy levels. An athlete needs to sustain energy levels in multiple ways, maybe for short bursts or over long periods of time. That energy really needs to be there. And then, as we were mentioning a moment ago, that mental part of this, that gut-brain communication that's happening via the vagus nerve communication pathway, mental resilience in an athlete really makes a huge difference. And also, as perspective here of shaping the ideal body composition, truly a critical aspect to what athletes want to achieve. Also want to make a note while we're talking about communication that dysbiosis has been linked in the literature to anxiety and depression as well. That's something to truly consider when you're looking at patients even that may present to you with IBS or IBD issues. The microbiome impacts performance, and this is really where we're going to start looking at the idea of the way the microbiome, again, impacts digestion, which, as Dr. Mary explained, influences bone mass and strength through hormone and immune regulation. Healing time from sports-related injuries, then, with a good gut health profile does improve. It's essential to have good gut health for proper absorption and nutrient use. And I'm going to take a quick aside here to talk about protein catabolism and soft tissue integrity. From a chiropractic perspective, really take a look at what's happening with the soft tissue if a patient is not holding the adjustments that we're providing. The body will take a look at muscle tissue like steak, and it will break it down. The bottom line goal for the body is to keep that organism alive. It really isn't looking at vital health at that moment. So if a person is digesting enough protein, which you need to ensure in and of itself, but they're not breaking it down and absorbing it, you're going to have some level of protein catabolism there. That's an issue because it also increases risk for injury. That's something that an athlete certainly doesn't want to have. A healthy gut elevates hydration status, it improves sleep, and also impacts the antioxidant defense system, or the redox signaling system. And this is important because healthy redox is associated with a balanced gut microbiome to prevent tissue damage from exercise, to protect against exercise-induced oxidative damage, to reduce fatigue, and then finally, it's just associated, bottom line, with the general physical status of an athlete. So as we go to the next slide, my question has always been, why guess when you can test? I wasn't aware of any of this when I was still a student. It was only after I got into practice that I had patients presenting to me, and I frankly didn't know what to do for them or who to refer them to in many cases. So as we look at diagnostics laboratory, and I do acknowledge that there are many labs that are out there. I've been using diagnostics now for nearly 20 years. I have their permission to share information about them. I'm not being paid in any way by them. I have to say that I am really an advocate for accessibility of patients to information about what's happening in their body. And the reality is, in many of these labs that I've worked with over the years, and just in review of what they offered, testing can be expensive. Particularly when I look at starting a test with a patient and then wanting to retest certain factors to make sure that we're getting the progress that we want to see. What I appreciate about diagnostics is that they have something called a Flexi Matrix panel that for $125 allows me as a practitioner to test up to 5 markers. Now, I wanted to share what I typically choose. You can choose whatever you would like, whatever you're following up on, but for me, one of the most important things I can review is ova and parasites. They take 2 samples and they look at the feces under a microscope. So if I'm having issues with Candida, if there is any additional pathogen there that I don't want to see, that actual microscopic examination is critical in my view. So that counts for 1. The bacterial stool culture counts as 2 tests, and this is really where I'm going to see what I'm working with respect to gram-negative and gram-positive rods and flora. I'm also going to be able to get a window into whether or not I have any additional bacteria that's present, either from a commensal or a friendly standpoint that I would want to see, or from a position where we need to eradicate some opportunistic bacteria that may have found an opportunity to form residence in the gut. I also want to take a look at inflammation levels, and the one that I typically choose because it has a smaller window of reference, tighter window, is lysozyme. Alpha anti-chymotrypsin is another option, but when I see levels of lysozyme that are high normal or elevated, I know that I'm working with inflammation. And considering this from the perspective of a subclinical state is also important. And then for my 5th measurement, I might choose either total intestinal SIG-A, which is critical in part because you're looking at the fact that, what is it, approximately 65% of our immune system is in our gut. You know, immunoglobulin A is the tagging system. It takes a look at something that's in the body that is foreign and says, look, I may kill you now, I may kill you later, but I'm going to mark you and I will be able to find you whenever I need to. You don't belong here, and I know it. Having that system in a strong measure of immunity is very important when you look at the overall vitality of a person. Or again, chymotrypsin, that is a measurement of pancreatic exocrine output. I'm going to be looking at digestive capacity, not hydrochloric acid function here, which I'll talk about in a moment. So those are my top 5. And while I may have somebody that could be at a state where they have more resources and they can afford to do additional testing, if I have someone and they say, I'm limited, this is an entry point for me. Again, it makes it accessible. And 2 final points that I want to make before we move forward is that I have chosen in my 20 years of clinical practice to not upcharge labs for patients. They're paying me for my time and expertise and my work to help them get better. I have patients pay the lab directly, so that removes a headache of billing for me, and that also helps them understand they're paying what I pay. I'm just trying to get access to information. So if we move on to the next slide, we're going to start talking about the patient that I have, and of course this isn't who he is, that's just a photographic representation of a male patient at approximately 37 years of age coming in with daily gas and intestinal discomfort. He talked about extreme bloating, so whenever he would consume dairy or gluten, he would almost feel pregnant, he said, or would just really be very tight as far as his pants. He'd have to unbutton. Very difficult for him. He said that it had started approximately 2 years prior with what he termed an overconsumption of dairy. There had just been issues ever since that point. And he had gone to his GP, had gone through an endoscopy and a colonoscopy with absolutely no answer to the issues that he was having. And so over that period of 2 years, he had lost between 10 to 15 pounds of, muscle mass. And he had begun to feel weaker and weaker. Now, this is somebody that was working construction. He needed his strength. And he also was a former athlete. He was used to his body performing in a certain way. And it was really difficult for him to deal with this issue. So in moving forward to the next slide, just to give you some additional information here, that sense of being weaker and weaker, again, was a huge point for him mentally and emotionally. I want to make sure to really stress that here. He also had great variability in his bowel movements with respect to consistency, color, and frequency. He vaped for nicotine. He was a self-described workaholic. So for him, he was really never in that rest and digest state that Dr. Mary referred to earlier. So stress was really impacting his digestive capability. And when I was sitting with him, he just described feeling desperate after 2 years of not being able to eat normally, he would call it. It was difficult for him to have a meal with his family. It was difficult for them to go out together and enjoy a meal. He was really convinced that something was wrong with him that would never be found, and that he wasn't going to improve. So in looking at the next slide, what I did was include here just to capture an overview. It's a lot of data to take in, but I wanted to give you the viewpoint here that when I first discussed the Flexi Matrix at 5 markers for 125, that's just an entry point. I ended up doing a modified Flexi with him where I included additional markers that bumped him up to just the next price range up from that, but you can order the full enchilada here. And in many cases, when I've had patients present to me that come with a binder full of information, and they've been to our University of Iowa Health Systems, and they've been to Mayo Clinic, and this has been an issue they've not had a resolution for some time. I want as much information as they are able to financially afford in that case. So I'm showing you an expanded gut panel just so that you see the options here. If we look at the next slide, that will really show you the final component to this, and we can talk more about what we did. I asked him as well to do the baking soda test, and I want to just point that out before we go into his specific results, because that is something you can have a patient do for free. Most people have access to soda in their home. I have the patient take a 1/4 teaspoon of baking soda, put it in between 4 to 6 ounces of water, and consume that upon rising, and to time how long it takes them to burp. If it's more than 5 minutes before they burp, I have them just stop timing, because it's not going to happen. And that is a clue immediately that there's a deficiency in hydrochloric acid. What's important to me about doing this test is that it really gives them, they feel it, they're experiencing it themselves, and that is really impactful. Doing stool testing or saliva testing, as it was with this patient, we did both. That's a test that you do the kit at home, and you send it away, and you wait for a person that you barely know to interpret it for you. The baking soda test is something that they can repeat as well as they improve in their journey. So this particular patient's results were the following. There was scant Candida albicans that had started, and although he had a heavy gram-negative and moderate gram-positive flora picture, which is what you want to have. Sometimes if it's really overt dysbiosis, there might be scant growth of one and moderate growth of another. You can see a true imbalance in the scale there. But he also had some presence here, again, of the Candida and 2 Streptococcus species that needed to go. You'll also note here non-toxigenic E. coli, and I want to be very clear that this is not the same E. coli that you are familiar with. Perhaps would give you food poisoning, that would hurt you. This is considered commensal. You want to see this with respect to good digestion. We looked at his total intestinal Sig-A on this. He was within normal limits there, but I did have high normal lysozyme. I will tell you, after doing this for nearly 20 years, that when it comes to this specific inflammatory marker, that if I see anything over, it will just be the less than 0.5 in its reporting, I know I have at least some level of inflammation that I'm dealing with. So he was really pushing it at a borderline elevation there. Chymotrypsin levels were also high. And this can happen if the patient has a loose stool, which he did. There are certainly other reasons for it, but that was true in this case. Alpha antichymotrypsin, the other inflammatory marker, was also high normal. So that was just a confirmatory measure for me that we really were working with inflammation that we needed to deal with. So interestingly enough, even though this patient said that he was really concerned about dairy, I had him consume a small amount, knowing that we would, if there was a reactivity there, an intolerance, that we would have some measurement of that through the saliva and the casein antibody that would be produced. And that was completely negative. He was borderline for a reactivity to the gliadin antibody. We did choose to test occult blood here because he was concerned about the presence of blood in the stool. That was negative. And then I had them look at the feces under the microscope, also negative for overt candida. Sometimes if I have such a huge overgrowth of candida that it can't be cultured, when they look at it under the microscope, then I'm able to see what I'm working with. As we look at the next slide, here's what I did. We started reviewing his dietary intake and eliminating foods. If we could just go to the next slide. Thank you. So we started taking a look at eliminating offending foods that he just knew were an issue. And part of that was the mental and emotional component. Remember, he'd been dealing with this for 2 years. He was broken down. He was hopeless. And so the interesting part of that is that it was hard for me to sort of begin reintroducing whole foods to the profile. Looking at fresh whole foods and reframing or reforming his relationship with food was pretty huge. We had to go to that "food is your friend" motto and have him, even at times, he would only do a couple of bites of something and leave it because that's all he could emotionally handle, and that's okay. As he began feeling better, his courage began to rise, and he was able to do a little bit more here with this. We also worked slowly to increase fiber in his diet to help bring bulk to those stools and to provide some good food to the bacteria in the gut while implementing stress-reducing behaviors to get him into that rest and digest mode as much as possible. Part of that was having him really, again, he was vaping for that nicotine, and he had to really realize that he wanted to be in the go, go, go mode all the time. When he began looking at that, there were some things that he discovered about his life and his relationships with others that were impactful for him in making changes with that helped him calm down a little bit. We also introduced several supplements, and he immediately was like, "Dr. J, I can't do much. Let's just start slow. I need to have, something easy." So we used digestive enzymes with betaine hydrochloride. We used probiotic with research strains. I wanted to get nourishment into his body. That was really important. So we used a whole food multivitamin, and we also used powdered whole food nourishment that he could use throughout the day to help augment the food that he was eating. Just to, again, nourishment is the word. When I'm working with students and I'm talking with them about how they can, work with patients when it comes to nutrition, that really is the bottom line. You need nourishment in order to be able to function well. And then I utilized okra pepsin, which has been so successful for me over the years. And just, okra is a vegetable. And so it's a mucilaginous vegetable that really brings soothing and healing to those tissues. It works. It's been tremendous for me. So in looking then as we move forward with the way that he responded on the next slide, he was astonished, and I'll never forget the first time that I saw him, just to do a quick check-in with him, which I'd like to do every 30 days as patients are progressing through a care plan. He could hardly contain himself because within that first 7 days, he really began experiencing pretty significant changes in that extreme bloating, as he called it, and the pain that he was feeling. And that really encouraged him to begin introducing those foods back in again. And he even started experiencing joy in foods that he hadn't been able to eat for some time. We all have foods that we love and enjoy that are connected to memories with our families and to good experiences that we've had, that really comes into play right around the holidays when people in certain regions, eat certain things. And it's so important. Food is a huge part of our life. So mentally and emotionally, his opportunity to begin reframing his relationship with food and cultivating that hope that he was healing was a big deal to him. He also reported to me that muscle mass was forming once again. And even within that first 30 days, he'd had an experience where he'd been required to use a jackhammer, an experience I have not ever had, but he was excited to report that he was able to do his job. You know, that was a point of pride for him. And I think that that should be acknowledged in this conversation. And he was able to do the job fully. So he held that jackhammer for 45 minutes and was able to show his colleagues around him that he was strong and capable. And so at this point, the patient is really symptom free. He does continue to use those supplements that I talked about. We've tapered off on that okra for him, you know, and he's just decided that further testing, you know, really wasn't necessary because of the results that he was having. An important point that I want to put forward here before we move to the next slide is to say that sometimes that's going to happen. But for other patients that really need to see in black and white that the changes that they made in their lives made a difference objectively can be really important to giving them the encouragement that they need. So as we go to the next slide, Dr. Mary is going to jump in here with me now. Hi, Dr. Mary.
Hi, I'm back here. Yes, great job.
Thank you.
Again, we're really going to talk about, you can see the last thing, customization is the key. So other things that when we were discussing this and talking about these cases, we might ask, how come you didn't do this? And we had our reasons with our patients or whatever, but we wanted to say, certainly when we're talking about the stomach and GERD, people can have nausea, and ginger just so great for that. And that we could have had ginger in there for that patient. I didn't happen to use it, but I've used it in other cases. We could have done some garlic also to sort of support immune function, and garlic's a platelet aggregating factor inhibitor, reducing inflammation, so we could have done some of that. To try to handle some of the lack of digesting and killing the bad bacteria, we could have done some Oregon grape, which is a source of berberine. Yeah, go ahead.
I just want to jump in here too, Dr. Mary. I have to say that in doing pre and post testing with patients over these years, you know, Oregon grape has been huge for me as a very easily digestible in the liquid format, you know, source of berberines. It's an antimicrobial. It
totally
is just
antimicrobial.
so much in and being able to remove these pathogens that are opportunistic in nature and could be playing a role in the poor health of the patient.
Yeah, I'll have you do slippery since it's helping more in the lower bowel. Go ahead.
So, I mean, slippery I have used this with patients as well. It comes in a powdered format and they're able to mix that and drink that. Again, it's another source of, you know, mucilaginous content that can help soothe and heal tissues on that. You know, the various enzyme complexes that we talked about, from, you know, hydrochloric acid, enzyme that has a little bit of zinc in it, that is so important, right? Zinc is needed by the cells of the stomach in order to produce hydrochloric acid. Do not forget about the baking soda test.
That's right.
But others, like a veggie enzyme as well, that works well for people. It just depends. There's lots of options there.
Lots of options. Yeah, we could do some oil of oregano, like we really are talking about trying to help heal the gut and trying to keep those opportunistic bacteria out of there, whether we're doing berberine or oil of oregano. And again, one more time about the L-glutamine as the preferred fuel. One thing I will say is L-glutamine is particularly high in the chicken and chicken soup. It has to have the bone in it. So I did have a patient that I will share with that did well on the okra pepsin, and but then we also had L-glutamine, and she wanted to do other things. So she actually started making chicken soup with okra in it because she was from the South. So you could do that too. It's actually whole food. And then Julie, I'm going to have you talk about the Dr. Julie customization. We're all big fans of that.
We are, and this can be overwhelming to people. We've talked to other colleagues. I know you have too, Dr. Mary, that are just like, oh, I couldn't do what you do. I don't want to do that. I can't decide what to do, and how do I approach this? And it really, comes down to just having flexibility. And just as with anything else, I mean, look, I've tried things. How about you, Dr. Mary?
I've tried plenty of things.
I need to try something else. Thank goodness there are other options available. I mean, not everything is going to work for every person. So you just have to be willing to keep trying and to find what works in that specific situation, for sure. So
we'll move to the next slide. We're almost done here. Thank you for staying with us this long. So we both teach at chiropractic colleges. We are very aware of evidence-based practice for chiropractic, but we want to say how much we are also fans of evidence-based nutrition practice, and that it is really a system where we're going to assess the problem, ask all those good questions, acquire all those tests, decide what does it mean, apply that, but also then to reevaluate and to be able to then make changes and follow the literature, which is of course always changing, but there's so many resources that you can use, and we're just going to say that is really important for us. And we found new things as we were getting ready for this too, like that new paper that came out in 2020. So we're always learning, working with patients, and we encourage you to do the same. Could be a little bit of a rabbit hole, but we do love going down it. Next slide. And for us, this is Dr. Johnson's slide.
So as we look at this slide, it's a handout that we also provided. We don't have the opportunity during this presentation to really go through it with you. And this is something that I modified actually from Herring's House, which I learned in doing my homeopathic medicine training. The thing to really pull out here is that as practitioners, we don't treat the symptom, but the person with the symptom in which it's expressed individually. So if you look at the arrow that's in the middle of the house, the top, you start with an etiology, but you've got to dig in somewhere. And so by following this, just as you would take someone through your home and show them different rooms, this can lead you through a step-by-step clinical thought process that you can utilize to help you work through some of the questions and challenges that will arise as you unpack a case like a good detective would with a patient, and trying to determine that right approach, the right technique, if you're looking at chiropractic, the right frequency, the proper duration, all of those things really matter. And a good clinical thought process can help you achieve that. This is something that I utilize to teach our students at Palmer and wanted to share with you to be able to utilize as well. So as we move on to our last slide and give you our final thoughts, Dr. Mary.
So we're hopefully at this point, you agree with us that the gut health improves everything, from decreasing their pain to increasing their performance and everything in between. That we are big fans of data drives decisions, that we're not just on a whim. So we really want you to get that there's such good data out there. There's so many good resources that you can use. And then finally, I'll give this to Dr. Julie. We both realized how important the thought process is. So we want to take that over then.
Yeah, that's really true. And I think that it's our experience working in academics that shows us as we work with students that are developing their own way of going through a clinical thought process, that it boils down to really looking at yourself like a good detective. And detectives will peel back the layers of the onion. They're always looking for what is the next right step. And sometimes you can't see too far down the road, but if you keep moving in the right direction and you use things like functional or laboratory testing to confirm, that you are moving in that right direction, it can be really important. Our bottom line to you is that there are many options to improve gut health. But if you take it seriously, you look at it, just pick one, and build from there. Work through that.
And then we both want you to say, you probably have patients right now that you could totally help. Make a list of those patients who are not holding their adjustments, those athletes who are getting injured, and then those people who are actually coming in and reporting symptoms that you know for sure are their gut.
Really one of the things, if you're thinking, I don't want to start, working with patients necessarily, maybe doing functional or laboratory testing, you can just start asking more questions, have them do the symptom survey form, and really use yourself. That's part of what I did, and I've seen others do, is just test yourself. Take a look at what's happening with your own gut health and work through that, and that can really be a great proving ground for you. So we've had a great time. I know I have with you, Dr. Mary, in preparing this presentation. I want to thank you publicly for agreeing to do this with me. I'm so honored to have done this with you, and we truly hope that this has change some perceptions for you. I don't know if it will be listed, but if there are any questions, you can reach me at julie.johnson@palmer.edu. I'm happy to help.
Yes, and I just want to reiterate, I had a great time with you, Dr. Julie. We've gotten to be great colleagues over the years of going to nutrition symposiums at Standard Process and also at ACC RAC. And so we're just blessed to be able to bounce ideas off of each other. So we recommend that too, that you maybe find someone that you can work with as well that can be there to support you as you work through with your patients.
Thank you.
Thank you.